Mr. President, the audience, I'm delighted to be here today and present this paper about maxillofacial surgery in Africa. Africa is the world's second largest and second most populous continent in Africa after Asia. It has 54 countries, and I'm mentioning this because sometimes when I go to Europe, or I go to South America, or I go to America, and I say I'm from Nairobi, they tell me it's Nairobi in Lagos. So you can see why that is very necessary. It has 54 countries, including one that has just recently been declared an independent state, South Sudan. 47 of those countries are in sub-Saharan Africa. Approximately, the population is about 1 billion. And I'm mentioning this to see that if there's a potential for the growth of maxillofacial surgery in the next 50 years, then that is one area where we shall look to. It accounts for about 14.72% of the world's human population. That's a graphical outline of that. It actually shows the size, and the next, the small histogram shows the populations. If we review the health systems in Africa, the story is not quite encouraging. In summary, Africa has 24% of the world's burden of disease, but only 3% of the world's health workforce, which means that when you look at oral and maxillofacial surgery, it is a very small, significant part of that. There is a very severe shortage of human resources for health in Africa. Sub-Saharan Africa has an estimated of 145,000 physicians. That's only 5% of the 3 million practicing physicians in Europe to serve a population of 821 million, more than the population of Europe. The other aspect which we have to know is that Sub-Saharan Africa has a physician-to-population ratio of 18 per 100,000, compared with countries such as India, where it's known that there are about 60 per 100,000. Brazil, and that can be confirmed from someone from South America, 170 per 100,000. And when you look in France, it's 370 per 100,000. Currently, you find there's one surgeon for every 196,000 people. This scenario changes when you go to rural areas where you might not even have one to take care of the people. And this cuts across, except maybe for about 3-4 countries that I'll mention later on. There is extremely very little data and publication related to the capacity of surgical services delivered in hospitals, which also will indicate that in the field of maxillofacial surgery, that information is not available because it doesn't exist. It is even more difficult to measure how much surgical research is being done. You have seen that we have been taken through in the normal lecture that has been given just before me, showing the development of how things have happened. But that is not the situation in Africa, where not much is being recorded of what is being done. There is a tremendous deficit of surgical care in the field of maxillofacial surgery, whether you are in the north or in the south. when we look at maxillofacial surgery, there is definitely a very constant evolution in that field. The International Association of Oral and Maxillofacial Surgery has done a great job, particularly in trying to put pressure in our governments and institutions to have maxillofacial surgery being recognized and institutions of training being established. However, most of the diseases that occur in this area have not been addressed to, and the need has not been met. Unfortunately, Africa is one area again where most of the infectious diseases like malaria, tuberculosis, and HIV/AIDS has taken a wider and more attention in terms of resources and in terms of what should be done than maxillofacial surgery, which means that the priority in this case has been put down to the lowest level. This is compounded by a lack of trained personnel in the specialty areas of maxillofacial surgery. There are very few training centers, and they are not able to meet the need. And I'll talk about that later on as we go along. Now, what this does, it doesn't discourage us, but it offers an opportunity for the profession to position itself in the next 50 years if they can be able to make sure that the institutions of higher learning, the governments, and the health sectors can be able to recognize that there's need and a great need for these services. Very briefly, there isn't much in terms of training. However, Africa, in terms of, we can divide it into three areas. There's a North Africa, mainly Egypt and the other Arab countries. We have the West Africa, which is mainly Nigeria, Ghana, and these are not the Anglophone. We have the East Africa, which is Kenya, Tanzania, and these are Anglophone. We have South Africa, and when we talk of South Africa, it's only South Africa as a country, but there are other South African countries like Madagascar, Zambia, Botswana, that actually fall within that region. And then we have the Central Africa, which is mainly Francophone. We are talking of Gabon, Cameroon, all those countries. Now, when you look in terms of training, the only place where there is actually a focus with a well-taught idea of how to train maxillofacial surgeons is mainly in South Africa. In North Africa, Egypt and Cairo University trains the people in that specialty. In East Africa, that's where we've had a great help from the International Association of Oral and Maxillofacial Surgeons, and I was happy to see John Williams, who has played a major role in this area. The only centers that are there is mainly University of Nairobi. The University of Nairobi program is more or less a 4-year program that encompasses rotations through the surgical specialties, intensive care, and medicine. While the one in Mombele University is a shorter program of 3 years, and when we look in terms of balancing it together, there is no what you'll call a standardized approach in training in these areas. West Africa, Nigeria leads in this area, but in terms of standardization, this is also not true at all. We also have colleges that tend to standardize, although their role has not been tremendous in terms of influencing what goes on in these areas. We have the College of Facial Surgeons of South Africa. We have the West African College of Surgeons. And recently, about 4 or 5 years ago, is the East and Central Africa College of Surgeons, where we belong. Now, when you look at the countries, the only countries that have got more than 10 maxillofacial surgeons, and they do not exceed 30 in those countries, are mainly South Africa, Kenya, Nigeria, Egypt, and Ghana. Now, Libya, which, as you know, has gone through a tremendous change in terms of civil war and everything, was mainly depending on expatriates coming out from other countries. But in the Arab and Francophone countries, very little is known. But through the outreach programs I've had there, there is no existence of maxillofacial surgery going on or training in those areas. So what are the challenges that we must address so that we can be able to have a wonderful, prosperous 50 years of maxillofacial surgery in future? Now, there are very few institutions, so we have very low physician to population ratios. And unfortunately, many of the African doctors who have come to train in the West or in America have opted to stay behind rather than going back to the country. And this has a very serious repercussions. One of those being that you do not have what we call quality faculty, which can be able to train the people back home, or even be able to do proper clinical practice and even research in order to position ourselves in the future. We also, there is very, very weak infrastructure. I'm sure some of you who have been to Africa, you find that the conditions available for operations, for example, are, you wouldn't be able to do anything at that particular moment. The time available for operations is not there because they have not recognized that this is a specialty that contributes a lot to the healthcare delivery in most of the countries. We have seen that maxillofacial has developed because of the war, the first two wars. Let me remind you that the civil wars have been the norm in most of the African countries. And as a result of that, most of the injuries that have occurred have gone unattended, and the complications have been great. Just very briefly, and I'm mentioning this because for the future research, for the future training, we find that there's a lot that we have in Africa. A lot of the conditions that I know in the West you see in the textbooks, we are still seeing them clinically in the field. Most of the conditions, whether you're talking of trauma, they are being seen where they are not being treated immediately, but they are treated after maybe 5, 10 months, if there is any treatment going on. The cancer patients that you see have gone beyond stage 3 and stage 4. The reasons being, many of these patients, first of all, they do not have people who can recognize and diagnose them in the rural areas. The access is not available. They have to travel many miles away. In the next 50 years, what we want to see is that how can we be able to reach all these patients in terms of increasing the number of the people that can be able to offer them. We need to look at the challenges that are there. That is not commodities, but it's commonalities in the clinical practice. We are looking forward to see, can we have a cooperation between the West and Africa and Asia so that we can standardize in terms of our clinical practice and be able to raise ourselves the same standards? Can we be able to learn from each other where the West was many years ago and where we are? Because from the lecture that we have had, it appears that despite the fact that some of us can do some good work, but this is not cut across in Africa. The other aspect that we find is that the industry, and I was happy to hear the President mention that many of them have been able to assist in this particular event, have not focused in Africa. We are looking forward to see them coming in and helping us in terms of their, helping us in research, helping us set up facilities so that we can be able to go forward and do good work. We need to see how we can be able to have a very good footing in the future. And this only can be if the associations can help us so that we can be able to make sure that the governments gives priorities. Some of the donor funding that's being done to the HIV/AIDS, to malaria, to tuberculosis can also be utilized to this particular part. And one of the things that I'll encourage you to do is to have what we call surgical outreach programs. This will set a foot in terms of patient care. It also help in training the residents, and it also help in terms of research opportunities for the future. Thank you so much. I appreciate giving me this opportunity. Thank you.